Welcome to the next case presentation for the Clinical Excellence Network. My name is Joseph Braithwaite. I'll be presenting a patient I had with a lateral ankle sprain. The patient was a 37-year-old male. This is a worker compensation case, and he had left ankle pain. That was all the information I was given to form an early hypothesis. My primary hypothesis was just a lateral ankle sprain, maybe a grade 2. The secondary hypothesis was that it was some sort of fibularis muscle strain, and the third hypothesis was that it was a fracture of the fibula, potentially post-op, and that's what I have to go with to begin. Here is a copy of the body diagram I was given also to help me form an initial hypothesis. When I was allowed to look at the rest of the medical chart, I discovered that the patient was a police officer. His chief complaint was left ankle pain and lateral ankle leg pain. And it was 11 days after the accident. And the LEFS was 67 out of 80, and the radiographs ruled out fracture. So the physician asked us to evaluate and treat for a lateral ankle sprain. These findings only slightly changed my early hypotheses, changed the tertiary hypothesis to Achilles tendinopathy. I began my history by determining that there were two different areas of pain. P1 was in the left lateral ankle, which was worse at 10 out of 10. That was soon after the day after the incident. Best is 0 out of 10. Currently it was about a 3 out of 10 with normal activity. Aggravating factors consisted of walking on the toes and tapping the ankle by himself. Easing factors includes anti-inflammatories, ice, and rest. T1, or time to onset, is instant. T2 is, or time to ease, is instant. The P2 was a lateral leg pain, worse 10 out of 10. Again, that was a day after the incident. Best is 0 out of 10, currently 2 out of 10. Aggravating factors, again, walking on toes. Same easing factors and the same time to onset, time to ease. The patient is 11 days post-injury. He was actually performing tactical training and rolled his ankle off the side of the mat. Currently he is working full-time, just light duty in the office. The pain began at 10 out of 10 at both P1 and P2. He was unable to walk and bear weight. Currently, it's dropped down to 3 out of 10 with most activities on P1 and 2 out of 10 with normal activity. But it can get as worse as 6 out of 10 now with walking on his toes. He has no significant prior history. The previous treatment is NSAIDs, ice. He wore a boot a little bit at work, and he's been resting. Radiographs were negative for any fracture. Medical history was unremarkable. There were no red flags, yellow flags, or special questions I had. The subjective asterisk that I would use will be walking on his toes and pain with self-palpation, or the tapping. My clinical reasoning using the CEN method was as follows. The severity was minimal to moderate. Irritability was minimal. The nature was musculoskeletal. The stage was acute, and stability was getting better, but it is reproducible. I have listed here some of the joints under the area and other structures which could be the cause of the pain that he is experiencing. After going through the patient history, my primary and secondary hypotheses remained the same. In planning the physical examination, I would include palpation of the lateral ankle ligaments, pronation, supination with overpressure, tensioning of the lateral ankle ligaments, assessing mobility of the joints of the ankle, and determine if symptoms are worse in standing. I would also continue to assess throughout the plan of care the tolerance to work-related activity and the patient's response to towel curl distraction manipulation and other foot mobilization. First off, I found no precautions or contraindications for this patient. The functional movement analysis, P1 was increased with coming up on his toes and was even made worse with walking on his toes. P1 and P2 were increased with supination with overpressure, and P1 was reproduced or increased with pronation and with overpressure. Functional activities, P1 was increased during push-off, a normal gait. Quick screening, clearing tests and whatnot, with the ritualistic examination, I was effectively able to rule out any lumbar spine involvement, hips or knee problems there. I did determine that the distal tibial-femoral joint was hypomobile, but mobilization of the mid-tarsal and subtalar joints was not irritating for him. Increased in P1 with palpation of the calcaneofibular ligament, and a slight increase in P2 with palpation of the distal lateral leg. The reflexes and sensation was normal, and the gross range of motion of his ankle was within normal limits. After the physical examination, my primary and secondary hypotheses remained the same, with H1 being lateral ankle sprain, and H2 is fibularis muscle strain. My historical and physical exam asterisk signs were coming up on his toes, especially walking on his toes. Also supination and pronation with overpressure and palpation of the calcaneofibular ligament. The plan is to assess his response to the talocrural distraction manipulation and other mobs of the joints in the ankle. Also, the plan was to progress the ankle strengthening exercises as the patient could tolerate. These are the treatments I performed with my patient on the first day, in order actually. I began with the talocrural distraction manipulation, which decreased P1 from 6 out of 10 to 3 out of 10 when coming up on his toes. I then performed a subtalar joint mob, which decreased P1 even more from 3 out of 10 to 1 out of 10. After performing inferior tibial-femoral joint mobs, P1 remains still at 1 out of 10. Exercises I had him perform included stabilization training or single limb stance on a foam pad. This increased P1 back to 3 out of 10 a little bit. He had some impaired balance control compared to his right side. Next, I had him perform tubing or band exercises with a blue band, dorsiflexion, plantarflexion, eversion, and inversion. And he felt some discomfort while performing these activities, but nothing significant. The patient's response to treatment on day 1 was very good overall. P1 and P2 were both decreased. The prognosis and goals were, I can see him 3 times a week for about 3 weeks. Hope to decrease or eliminate, actually, left ankle and leg pain with all activity and to return to full-time full work duty. There's no precautions and no contraindications treatment. The plan of care is to continue using the talocrural distraction manipulation, the distal tibio-femoral mobs, and other mid-foot mobs to help modulate the pain, and then to progress his functional strengthening exercises of his left lower extremity, especially as he tolerates, to help the patient return to full-time full work duty. The patient came in for his second visit a few days later, and I asked him the 5 questions. He responded that he felt quite a bit of relief after last treatment, and that his symptoms returned to 6 out of 10 with walking up on his toes. P2 actually was barely noticeable with all his activities. He was compliant with his home exercise program, and he reported most difficulty, again, with the push-off phase of gait and walking on the toes. No objective data was collected on the second visit. Here you can see the patient's response to the treatments of the second visit. I performed the same manual interventions with some variation. It decreased his pain down to 1 out of 10 at the end there. Um, Exercises I included, again, were the band, the blue band, stabilization training, which he improved. There's just minimal increase in pain. I actually had him perform some step forward and lateral with a 6-inch step, with only a slight increase in pain. And then I taught him how to do a lateral distraction self mode for his home exercise program, so he can help modulate the pain at home. On the third visit, the patient reported feeling quite a bit of relief again with the left ankle symptoms since last treatment, and actually an overall decrease generally of 4 out of 10 today with walking on his toes. P2 is non-existent. It's not bothering him at all anymore with all activity. He was compliant with his home exercise program. He demonstrated them well. Patient also continues to report difficulty and pain during the push-off phase of gait. It's lessening though. And again, no objective data was collected. With the third visit, interventions performed similar manual therapy with a similar decrease to 1 out of 10 pain in the left ankle with coming up on the toes. The exercises I included were again the band activities, a step forward and laterally with actually a 12-inch step with no increase in P1. Performed wall squats with no increase in pain. Forward lunging actually did increase the pain, especially on push-off. So we stopped that after just a few. And then we also incorporated a BAPS board in both standing and sitting. That increased actually as well the P1 when standing, but it was not very irritable when sitting, so we performed it in sitting mostly on the third visit. On the fourth visit, the patient reported feeling less ankle symptoms again after last treatment. He reports 2 out of 10 pain with walking on his toes today, and no complaints again with P2, has not come back. He was compliant with some exercises, and today he actually reports very little pain in the lateral ankle while walking on his toes, as mentioned. The lateral distraction manipulation I performed today actually decreased his pain down to 0 out of 10 with coming up on his toes. For some reason I decided to try a subtalar joint mob after doing that, which actually slightly increased his pain a little bit, so I stopped doing that real quick. And then for the rest of the treatment, all the exercises that we performed, which did not increase any P1 pain, and I was able to actually increase the complexity of the exercises as well, such as step-ups on the Bosu ball instead of a stable surface. And he was able to do the BAPS board in standing. I even performed some plyometrics with jumping side to side over a taped line on the carpet, and even jumping up onto a 12-inch box and down. No increase in symptoms. Because of the patient's positive response to last treatment, we decided this fifth treatment would be the discharge. And the patient reported, again, no lateral ankle symptoms with activity since the last treatment. He reports no pain in P1 or P2 with all activities today. He was compliant with his home exercises still, and he reported, again, no pain at all in all activities. Since there was no pain with activity, I decided to not perform manual treatment today. Instead, I decided to try more advanced exercises, see if we could reproduce the pain at all. So we did tubing exercises, or the band exercises with the purple band, quite a bit of resistance. We had him step forward and sidewards again on the Bosu ball. Even had him step up forward onto a 24-inch staff. Had him do the VAPS board standing, and actually performed a dynamic single leg balance exercise, going forward and backward to both sides. All the exercises were negative and reproducing any pain, and I felt confident that the patient was able to progress at home in a self-directed home exercise program. So at discharge, his lower extremity functional scale was 80 out of 80. It was just 11 days after the initial eval, so 5 visits later. He had 0 out of 10 P1 and P2. He was able and committed to perform a self-progressed exercise at home, and he was cleared by his physician to return to full-time, full-duty work. What would I have done differently? I wish I knew more about some of the best evidence with regards to lateral ankle sprains and rehab before I saw the patient, such as the predictor variables, worsening when standing, worsening in the evening, a navicular drop, a tibial-femoral hypomobility, all predictors of lateral ankle sprain. I also learned the importance of the talocrural distraction manipulation with persons with acute or subacute lateral ankle sprain. Also some of the stabilization retraining and the benefit that it has with this population. Hypothesis-based reasoning affected me by helping me rule out more serious pathologies. I was also able to portray confidence in my diagnosis and better help my patient. Does anybody have any questions about my presentation, any of the treatments I performed, or my clinical reasoning? Please write down your questions and ask me on Tuesday. Thank you, and see you then.